like to welcome everybody today. Glad everybody was able to get out. I know it's been a few years since we've been able to have the health fair in person, and we love seeing everybody out and about and joining us today. This morning we have Dr. Matthew Bosner, cardiologist, and Morgan Ritter, a nurse practitioner with Dr. Bosner. They're going to speak with you today on heart issues.
Okay. Well, welcome everyone. We're really happy that we're able to do the health fair in person this year. It was a little bit challenging over the last couple of years. We had some online talks, but it's never the same. We have a new CEO, and it's the first time he's been here. Everybody's been warning him about 300 or 400 people walking around the hospital, but I think he believes us now. I really have to praise the marketing department. You know, as you guys have been here before, and most of you have, they didn't expand out. We expanded out this year, so down the old med surge and then towards the new part of the hospital, so you could at least move. A couple years ago, you really couldn't move for elbow room, and I really felt bad for people who had walkers and stuff because it was hard to get through. So I think the organization is really good. Well, Morgan and I are the providers of the cardiovascular team. And I do say the word team because our care and most of the care here in the hospital is a team-based approach. So we're the providers who see you in the clinic. We have nurses, medical assistants. Michelle Champion is our nuclear medicine technician, helps us with stress tests. Kelly Schwent is our echocardiographer who does ultrasounds and also does blood vessel ultrasounds, and she helps us a lot. We work closely with the pulmonary team to get pulmonary breathing tests, Carrie Staub, and of course the dietitians are very, very helpful. And I can't not mention the cardiac rehab team. And we'll talk about cardiac rehab as a really important part of cardiovascular care. And Julie Terry and the other nurses are there, and we have a rehab program specifically for individuals with heart issues, individuals who've had a stroke, individuals who have chronic breathing problems, COPD. We have a very focused COPD pulmonary rehab program, as well as peripheral vascular disease. If people have blockages in their arms or their legs, we have a very specific program for that, and that'll help people get stronger. And it's actually a Medicare requirement to go through 6 months of rehab for vascular disease before we can really refer you to a surgeon for revascularization. And a lot of times people get better just by exercising and improving the circulation in their legs. So that's a lot about the services we have here, and we'll talk about that as we go through. Next slide. This slide is Haleakala volcano at 2:30 in the morning in Hawaii before the sun comes up. So it was quite a challenge to get my little kids out of bed. And we went up to the top of the mountain, the top of the volcano, and we were going to be biking down, but we were there before sunrise, and it's really beautiful. And as we go through the talk, you don't see very much down here, right, because the sun isn't really up yet. But hopefully as the sun rises, you'll learn more, and by the end of our talk, it'll all be clear, and we'll be able to teach you and answer your questions about your cardiovascular situation. Next slide. All right, so the key feature why this is such an important topic, and we try to do a cardiovascular talk every year, is for men and women, especially people over the age of 50 or 60, cardiovascular disease is the #1 cause of death in the United States. About 600,000 people have a heart attack, their first heart attack a year, and 200,000 people have a recurrent heart attack or their second or third heart attack. About half the people who have a heart attack die of their first heart attack, really never even make it to the hospital. But with our approved treatments, once you do get to the hospital, the acute care, the medical care, and surgical intervention really saves lives and keeps people alive and doing well. The numbers are remarkably close for stroke. There's about 600,000 first strokes a year, about 200,000 recurrent strokes a year. But as you can see, the death rate for stroke is a lot less. A lot of people think that, I'm going to have a stroke and I'm going to die from the stroke. The biggest issue with stroke is not death. I mean, death obviously is important. It's the debility of the stroke. What happens after the stroke? How do you recover? It's a huge issue related to family care, to your chronic care management. So mortality is the big thing we're concerned about with heart attacks, and with stroke, morbidity, which is that once you survive the stroke, getting your post-stroke care is really very important. About every 40 to 60 seconds, someone dies of a heart attack or stroke, and that's basically really important. And that's why when you come to the hospital here, and a lot of hospitals, it's called time-critical diagnosis. If you come in to our hospital, Mercy, Barnes, with symptoms of a stroke, within 10 minutes you're going to have a CAT scan to make sure you didn't have a bleed into your head, and then we'll get you set up to go to a stroke center. And if there's no evidence of bleeding, we'll frequently give you blood thinners as long as there's no bleed in the head on the first CAT scan, because that definitely opens up the blood flow and the circulation and improves patients' outcomes. Next slide. This is an example that is very important for Morgan and I, because this is an example, a cartoon of a body, and here's the heart. These are the blood vessels which go up to the brain, and these are the blood vessels which go down to the leg. Here, we have an example. This is an example of a heart model. Now, this would be a heart of like a cow or like a horse, because the heart is about the size of your fist. Okay, so here is the here would be an example of like a kid's heart. Okay, this would be an example of my heart or Morgan's heart, and just for demonstration purposes, we like this because it's bigger. So the heart is the main pump. The heart is the engine of your body. It pumps blood, and it comes out a tube called the aorta. It's the main tree that is the blood vessel, and then you have branches that go up to the brain. Those are the pulses you feel in your neck. You have branches that go to the arm, the left arm and the right arm, and then it branches like a tree. So the thing that's important for us is that all these blood vessels in your body are connected. Okay? So for example, if you have a significant blockage in your heart, there's a 1 out of 3 chance you have a significant blockage in either the blood vessels that go to the brain or the blood vessels in your body or your arm. Okay, so for example, if one of the surgeons wants to do a carotid surgery for someone who has a blockage and had a stroke, they'll ask for a cardiac evaluation. Not is the patient going to survive surgery, the surgeon knows that. They want to make sure their heart is strong enough to undergo the operation. So that's why it's a team-based approach. We work with the vascular surgeons, with the neurologist. So if someone has a blockage in their abdominal aorta, what's called an aortic aneurysm, an enlargement and dilatation of the blood vessel in the body, we'll often do a stress test to make sure the circulation in the heart is good. So this is just to remind us that the blood vessels of all the body are connected. This is a sample of an aortic tissue of a young person, 16-year-old, who died in a motor vehicle accident. The patient didn't have, diabetes, didn't have any smoking history or anything like that, but you can see these thick streaks. This is already atherosclerosis beginning in a 16-year-old. And as you can see, it kind of tracks towards the blood vessels. Okay, so over time, as these plaques and irregularities get bigger, it might obstruct this blood vessel as we get older, and that's why we want to intervene. But this is striking to me because this is a 16-year-old, who hadn't had a heart attack. So this tells us that the process begins very early. Next slide. So one concept that you've heard of from us and from your primary care doctor is risk factors. What puts you at higher risk for having a heart attack, stroke, or peripheral vascular disease? See, we're not talking just about heart disease. We're talking about blood vessel disease through your body. Well, we break it into 2 groups. The way Morgan and I look at this is we have what we call modifiable risk factors, which is things we can change, and things that we really can't change. So, for example, smoking. We're going to talk about smoking in detail, but smoking is an acute toxin on the cardiovascular system. Okay, smoking causes squeezing down of blood vessels, causes blood clots, and is definitely associated with heart attacks and strokes. When there started being smoking bans in cities, in the class there was a big study done in Des Moines, Iowa. When they stopped smoking on the weekends, all the heart attacks that occurred at the bowling alley and in the movies, because everybody went to the movies, went away. And the reason is smoking. So the key point about smoking is that it doesn't matter how long you smoke for 10 years, 20 years. If you stop smoking, your risk for heart attack or stroke goes down significantly over the next couple months. Now, smoking has a cumulative effect on other disease states: lung cancer, pancreatic cancer, esophageal cancer. Mary and Debbie talked about that a little bit earlier. So that's why when we see patients, or your primary sees patients for smoking, they'll talk about pack years, which is how much you've smoked, how many packs of cigarettes over the years. Okay, that's related to your cancer, really your cancer risk. What we talk about was how much do you smoke now. Okay, that's why we really push about not smoking. Someone says, oh, I smoked for 60 years, what's the difference? Well, this is the difference. Your risk of a heart attack or stroke is going to go down significantly. So smoking, smoking, smoking. We talk about that a lot. Abnormal fats in your blood, Morgan's going to talk about this extensively, as well as high blood pressure. So these three factors, smoking, abnormal cholesterol and fat in your blood, and high blood pressure, what we call modifiable risk factors, which are risk factors that if we change will improve and decrease your risk for an event in the future. But what about other risk factors? We know as we get older, we have a higher risk for heart attacks and strokes. So you can't really change your age. The issue related to sex is that men and postmenopausal women have equal cardiovascular risk. Women who are premenopausal have significantly less risk, and it's likely related to hormonal relationships and such. But once women go through either chemical, surgical, or natural menopause, their risk goes up significantly. So that's why we start seeing issues in their 50s and 60s, as opposed to men who we commonly see issues of heart disease that may occur earlier. The other issue is family history. Well, my dad died of a heart attack. My grandpa had a stroke. The key next question that we ask immediately is, did they smoke? Right? Because think about the generations prior to us, smoking was a lot more prevalent than it is now. If grandma, grandpa, mom, and dad were smokers, okay, that pretty much is the reason why they had a disease. They had their cardiovascular disease. I'm not saying we don't worry about that family history, but it's very different than if your mom in particular had a heart attack at age 48 and wasn't a smoker. That is a huge familial risk. So the history has to be parsed out by that. So then we have a group of diseases which already put you in the high-risk category. So this side of the slide is the high risk, which is people who have already had an event. If you already had a heart attack or stroke, that in and of itself, there is no more risk factor modification. Risk factor stratification. You're at high risk for a second event. That's why we need to treat immediately once you've had an event. And that doesn't matter if you had a heart attack, if you had a stroke, you have a blockage in your leg. All these people need to be treated aggressively. People, after you go to the eye doctor, if the eye doctor is concerned that you have blockages in the blood vessels behind your eye, that's kind of a lens to the brain that tells us there's probably blockages in the brain, so they commonly refer to us. And people who have chronic kidney disease. People who have chronic kidney disease are at high risk for heart disease also. And the other group are people with diabetes, and Morgan's going to talk a lot about this. So if you have diabetes, your risk of a heart attack or stroke is the same as a person without diabetes who's already had an event. And she'll show the data on that. Next slide. Oh, here's the data right here. Okay, so I'm going to talk about this. Okay, so we have two groups of people. We have diabetics and people who are non-diabetics. This group are people who have not had a previous event, and these group are people that had a previous event. So if you look in the non-diabetics, somebody who has already had an event, their chance of having a heart attack or stroke in 5 years is 18.8%. But look at the diabetic group. This first group is the group who have not had a previous event, right? They have diabetes, but they haven't had a heart attack or stroke. And look, the bar is the same height. So these people who have diabetes and have not had a previous heart attack or stroke are at the same risk as our friends who are not diabetic who's already had a heart attack. So that's why we're very, very aggressive about treating people with diabetes for concurrent heart disease. As you can see, someone who has diabetes and had a previous event has almost a 50% chance of having another event in 5 years. That's why getting into your doctor and getting treated will decrease your risk and is really important. Next slide. This is just an example of what a heart attack is. A heart attack or stroke is basically you have a blood vessel, and we can pass these around. This is an example of a blood vessel, and there's a break in an irregular portion of the blood vessel, and we get a blood clot. So it's a blood clot blocking off a blood vessel that's diseased. This is why we treat people with aspirin. This is why we commonly prescribe aspirin to prevent these blood clots from occurring. Next slide. Okay, now Morgan's going to talk in particular about high blood pressure, cholesterol, and diabetes, and then I'll come back and talk about management. Thank you.
So as Dr. Bowser talked about various risk factors, our goal is to analyze and evaluate each patient specifically for their own particular risk factors. So as you can see, the cardiac risk evaluation starts with evaluation of a personalized evaluation, and we set goals by those risk factors individualized to each person, and then we treat based upon what that risk assessment shows and the goals that we've created together. So this is a good picture of taking a blood pressure. I know it seems simple, but accurate blood pressure measurement is very important when it comes to treatment and our management overall. So this individual is seated. It's important for an accurate blood pressure to sit down, wait a few moments, and then we have the blood pressure being taken on a bare arm, seated at the level of the heart here. Often we'll take the blood pressure in both arms because you can sometimes have a variation between the two, and we always want to base our treatment off of the higher blood pressure because that can often be our average. So seated after a few minutes, bare arm at the level of the heart to get an accurate blood pressure. So this is a diagram talking about our goals for blood pressure management. Overall, generally speaking, our theme is going to be the lower the better and everything that we're talking about today as far as toleration goes. But these are our goals that guide our treatment in the clinic. So for the normal average person, our goal is going to be less than 120/80. If you've had an event or diabetes or chronic kidney disease, we're going to treat for lower, 130. And then if your diastolic is greater or equal than 85, we're focused on that. And then over 40 with less than or 1 cardio risk factor, 140/90 is acceptable. And then if you're over 60 and you don't have any risk factors, which is not very many patients in our population, but we don't treat unless we hit greater than 150/90. So generally speaking, lower is better, but these are kind of the numbers that guide our treatment guidelines. So in regarding to the blood pressure and the impact of those values, as you can see, the optimal blood pressure over 12 years is lower for incidence of events. So optimal was the 120/80. In the middle here is the normal, which is 120 to 130 over 80 to 84, so lower. But then you can see that here in the high range of normal, so the 140/90, there are certainly more incidents over time. So that just goes to show that blood pressure measurement and accuracy and treatment is very important over time. So for individuals over the age of 50, systolic blood pressure is what we focus more upon. And then starting at 115/75, your 10-year risk doubles each time that it increases in the amount of 20/10 millimeters of mercury. So normotensive patients at age 50 have a 90% lifetime risk of developing hypertension. So that would be your average individual at the age of 50, even with normal blood pressure over time. It's important to continue coming to the doctor and having your routine screenings and blood pressure checks and lab values so we can help detect and treat, because 90% of individuals will develop hypertension over time. And then in the pre-hypertensive patients with the 120/39 range or the diastolic of 140/59 should still receive that lifestyle modification, education, and follow-up, because even if you're pre-hypertensive, it can certainly progress and then put you at a higher risk category. So back to our initial slide, which we're going to keep hitting this home about, is that we're going to evaluate every individual based upon their personal risk factors, set the goals. We're going to treat to target, but also, most importantly, follow up. So obviously important to come initially and get on a treatment path, but more so to follow up and ensure that we're still on the right track for success in the future. As far as cholesterol goes, once again, we're kind of highlighting the goals of therapy here. So for your total cholesterol, desirable is going to be less than 160. Anything over 200 for total cholesterol is considered high. As far as LDL cholesterol goes, that's the bad cholesterol, as everyone calls it. Less than 70 is the best, especially for someone who has had a previous risk factor or cardiovascular event in the past. A lot of guidelines are pointing out that in the future our goals are going to be lower and lower. So once again, the whole lower is better is certainly true of that of the bad cholesterol and cholesterol overall. But for the general population, we shoot for less than 100. Greater than 100 is still borderline, 130 to 189 high, and greater than 190 is very high, and it would be very important to seek treatment for that. For the HDL, or good cholesterol, in males, anything less than 40 would be considered low, less than 50 in females is low, and greater than 60 is high. So that's the good cholesterol that helps kind of offset your cholesterol risk ratio. And then triglycerides are something we pay attention to, but we mostly focus upon cholesterol, total cholesterol, and the LDL. But triglycerides, often go hand in hand with our diabetes and blood sugar and things of that nature. So we kind of talked a little bit about, those with heart disease, diabetes, kidney disease. Our LDL goal is going to be that less than 70 because your 10-year risk is going to be greater than 20%. The average population, or just one risk factor, would be the less than 100. And no risk factors, we're a little looser with our goal as far as less than 130. But generally speaking, less than 100 for the general population and less than 70 or even lower for those that have a history of heart disease. So everyone's very familiar with statins as far as treatment goes. So we know that there was a study performed in Europe called the 4S study with greater than 4,000 individuals in the study. And over 5 years, the group that was on a statin had a 25 to 30% less events of cardiovascular events than those in the study that were not on a statin, separate of the LDL and cholesterol levels. So that study showed us that even if you're not at goal on a statin, the fact that you can be on one or tolerate one to some extent is helpful in and of itself. So we are very pro-statin therapy because we know that they help reduce events over time. So total mortality, heart disease mortality, stroke mortality, any major coronary events, peripheral vascular surgery, and procedures. So back to the evaluation, assessment, setting goals. This is true for diabetes, high cholesterol, high blood pressure. Every single disease process we want to be focused upon and setting goals, treating to target, and following up again and making sure that we're still on track. As far as diabetes goes, I know Dr. Bosner kind of hit on this a little bit, but the risk of your heart disease is increased 2 to 4 times in those with diabetes. And it's not necessarily your elevated blood sugar that leads to death in a diabetic individual. It's the heart disease, the stroke, and things that cause the events that will take your life. So 75%, 25%, and cerebrovascular disease in the diabetics. And it can cause greater than 75% of all hospitalizations for diabetic complications. Increased morbidity and mortality post-heart attack and stroke, which is more profound in women. Dr. Rosner hit on that a bit too as far as the postmenopausal women. Most definitely is more profound effects in diabetes and heart disease. And this was an interesting statement to me, is that patients that are newly diagnosed, so if you just got diagnosed with diabetes, you've already had glucose intolerance for 5 to 10 years prior to diagnosis. So that goes to show that this is over time, builds over time, and is very important to get on top of and lower our risk overall. So it's not a risk factor for cardiovascular disease. It is equivalent to the pre-existing cardiovascular disease that Dr. Bosner showed in that slide with the diabetes patients compared to those with the prior events. So this also kind of shows the A1C goals and mortality and events. So our A1C for less than 6%, you can tell is much lower for mortality and events as compared to middle of the road A1C goals and the high A1C goals. So we certainly aim for lower, again, on your A1C for diabetes as greater than 7.9% or 8 range, shows the 15 plus in mortality and cardiac events. And this also highlights that the diabetes, in addition to hypertension, and only elevates our risk. So with hypertension alone and diabetes alone, the incidence of MI is 20 or 14, 15. Then when you add diabetes onto that, hypertension and diabetes, your rate significantly climbs up. Then you add cholesterol on all three, and it's very important to control all three of those, as it certainly shows the increased risk there. So this is a good graph about our glucose levels. So the first one is like a fasting glucose. So we usually shoot for less than 100 on a fasting glucose because it shows that impaired fasting glucose is greater than 100. And if your fasting glucose in the morning is greater than 126, that would be considered diabetes. And then the 2-hour postprandial blood sugar reading is often focused upon in OB. I don't know if you remember taking, or if you guys even did 1-hour glucose test back then, but now most definitely every pregnant woman will get a 1-hour fasting glucose test. And then if you fail that, they do a 3-hour fasting glucose test, because that shows the best evidence about how our body is responding to glucose and insulin. If 2 hours post a meal, if your blood sugar is greater than 140, you have impaired glucose tolerance, and then if it's greater than 200, 2 hours post a meal or a snack, then that would be evidence of diabetes as well. So as far as central obesity and insulin resistance, so in males, if your waist circumference is greater than 40, and females, a waist circumference of greater than 35 is also indicative of insulin resistance. So kind of on that path, which is another reason why we promote, healthy overall diet, exercise, to try to keep a healthy BMI and waist circumference size. And as far as key diabetes tests that we perform routinely, this has a lot of information on it, but ultimately we should be checking our A1C 2 to 4 times per year with the target goal of under 7. The HDL, or the good cholesterol, we want at least once a year in the general population so we can detect and diagnose. Same with the LDL. General population goals under 100, lower for those that have previous events. And triglycerides kind of go with the cholesterol panel. Blood pressures should be checked less than 130 for general. The microalbumin, eye exam, foot exam, just routine health exams yearly, I think is what I can't stress enough to help detect, treat, and follow up all of our goals.
All right, so I'm going to bring up a little bit of discussion about treatment, and then, of course, we're going to open up for questions and answers. Next slide. So you guys got this down now. If we give you any test, you got it. So we evaluate, we assess your personal risk and set goals, and then we treat to what your individual goals are, and then follow up. Whenever we change a medication, we change a treatment, we always have someone come in within a month, and then we stretch out your visits. If we change your blood pressure medicine, if we change a new medicine, we want to make sure you're tolerating it, because if you're not tolerating it, you don't take it, it doesn't do you any good. So we always have people come back in a month where we make a change in their treatment plan. Next slide. So these are our goals of therapy, and Morgan talked about this. Your diabetes, the hemoglobin A1 of less than 7, closer to 6, if we can do that. Blood pressure 130/80, LDL cholesterol less than 70, and absolutely no smoking. Not just cutting back, we have to stop smoking. So if we're going to do anything for your cardiovascular risk, this is far and away number one. No matter how good your medication, no matter if you've had a bypass or anything like that, if you still smoke, you're still going to have a very high chance of a recurrent event in the next 5 years. Next slide. So let's talk a little bit about diet. Okay, and the goal of diet is to get you eating healthier foods, non-processed foods, get rid of simple sugars, and kind of be careful of overall dairy products and meat. And it's not to eliminate these. We're not saying everyone needs a vegetarian diet, but basically we want to get your portion size down so you can maintain a healthy diet and lifestyle. Next slide. Okay, so this is probably the most common slide that people really want to pay attention to. I should have made a handout for this, but this is how we look at it. Okay, so the question is, what should I weigh, right? What's normal for me or my husband, right? So this is the standard Metropolitan Life table for calculating weight. So ideal body weight. For females is 100 pounds for your first 5 feet, then 5 pounds per inch over 5 feet. So, I know, everybody's getting their calculator out. Okay, so, and for
Take a picture.
yeah, we really should have had a hand. The last time I did this, we had a handout, but I didn't think about that. Okay, and then males, it's 106 pounds per inch, for your first 5 feet and 6 pounds per inch. Okay, so then you know what your body weight is. So let's say it's 150 pounds is your ideal body weight. What can you eat to kind of maintain your body weight with the normal amount of exercise? So the answer to that is 10 to 12 calories per pound. So if you weigh 150 pounds, right, a diet with a reasonable exercise should be about 1,800 calories. I mean, and that's a rough estimate. Now, but this is the key one. Okay, so you figure out your caloric intake. You say, okay, I'm eating 2,000 calories a day, 2,200 calories a day. What do I have to change my caloric intake to lose weight? Okay, so we'll get to the bottom line here. It's 600 calories per day to lose 1 pound per week. And that comes from a calculation of how much energy is in fat. What a calorie is how much it takes to burn a certain amount of foodstuff. And for fat, it's you get 9 calories per gram, and there's 450 grams in a pound. So when you multiply all that out, it comes to 4,200 calories. You have to decrease your caloric intake 4,200 calories a week to lose about a pound. I mean, that's a rough estimate. Increasing water intake is very important because it keeps toxins flushed out of your system. Also keeps you going to the bathroom, which is good. Spread meals out and don't skip meals. Okay, this is really important. Breakfast is called breakfast because you're breaking the fast of the night before. So if you skip breakfast and just eat lunch, your body thinks you're in a fasting state, so it's actually going to absorb more calories. So you're better off eating something for breakfast, be it a piece of toast with, a little jelly or butter, or an egg, or some cottage cheese or yogurt. And a little fat is actually good too, because fat actually quelches down your appetite. So you should eat something for breakfast and spread your meals out over the day. And try not to eat especially fat like 3 hours before going to bed, because your body doesn't have time to work it off, right? That's just kind of logical. So, people that don't eat because they're busy, they're working, they come home at 7 or 8 o'clock at night, then they eat 1,500 calories with their dinner, that might make sense because, it's only 1,500 calories. That's what I'm supposed to take. But the problem is if you eat it at 8 o'clock at night and you go to bed at 10, your body doesn't have time to burn it off. You're better off spreading that 1,500 calories over the course of the day. Okay? And we commonly refer to dietitians for evaluation, and we were marketing the hospital to get a second dietitian, and Morgan and I think, are successful for that. We have a new dietitian who started with us this month, so it's going to give a lot more access to individuals to talk about whatever you want to talk about, be it weight management, be it diabetes, and other issues related to diet and nutrition. We have 2 excellent nutritionists and dietitians, so just talk to your primary care provider to get a referral. Next slide. Okay, so this is just briefly, we just talked about this. Keeping saturated fat down in your diet is actually more important than cholesterol in your diet. And the reason is it'll prevent diabetes and it'll prevent total cholesterol from going up. Dietary options to enhance LDL. Cheerios, oatmeal, whole grains, using darker carbs than lighter carbs. So that means sweet potatoes versus white potatoes, rye bread or whole wheat bread versus white bread, those kind of things. And then basically adding as much as you can to your diet with fiber, fresh fruit and vegetables. Fresh and frozen are pretty equivalent nutritionally. It's the canned vegetables that kind of mess things up. And increased emphasis on weight management, and we'll talk about physical activity in a few minutes. Next slide. Okay, so this is, I love this slide, because basically, your dog is in good shape. You see, that dog's not overweight, but look at this dude, right? So when he comes in and tells you, yeah, he walks every day, he takes his dog for a walk, but this doesn't help very much. And the other thing we tell people is we want to exercise, and Rob talked about this. I don't know how many of you guys were here for the osteoporosis, but it's the same idea, right? You want to exercise 30 minutes a day, at least 5 days a week, to the point where it's a little bit hard to talk. That's the easiest way to remember. If you go with your girlfriend or your daughter or your mom walking, or your friends, your neighbors, if you're chit-chatting, you're kind of catching up on life and everything and bragging about your grandchildren, that all people do, including me, okay? When it's just hard to talk, that's a good exercise level. And that's where you want to keep it at 30 minutes. It's like people who go on a treadmill. It's like you have like a 5 or 10 minute warm-up period. You do your 30 minutes of good exercise at 70-80% of your predicted heart rate. Then you have a cool-down period. So your total time on the treadmill might be 40 minutes. But it's only 30 minutes of what we call good cardio exercise. So, and the more, like Morgan said, the more the better on exercise. Okay, next slide. And smoking. Smoking is really a problem, and we talked about that. And here's a couple cartoons I put up here. One is the smokers are on this side. You can see all the gravestones. The non-smokers are over here. And then it helps you relax. Yeah, it helps you relax, but that doesn't really mean anything. And this one I love. So the gal says, "I'm so proud of you, honey. You haven't smoked for a week." Well, meanwhile, the guy's in a hospital on a ventilator, which is why he can't smoke. So and you'd be amazed how many people we have on oxygen who take their oxygen off to smoke and then put back on their oxygen. It's just whatever. Okay, next. Okay, so this is kind of our summary slide. We talked about exercise. 30 minutes a day, no smoking, working on your weight situation, getting your cholesterol down to goal, your blood pressure down to goal. If you're diabetic or have glucose issues, getting your levels down, and as Morgan said, the lower the better. We recommend an aspirin 81 milligram a day if you've had any kind of cardiovascular event in the past, you have more than one risk factor, or you have diabetes. There's been issues in the literature and the newspaper about, people over the age of 60 don't need an aspirin. Well, that's if you don't have risk factors, and if you haven't had an event. So if you've had a heart attack, stroke, bypass, diabetes, you smoke, you should still be taking an 81 milligram aspirin a day. It'll also decrease your risk for colon cancer. Next slide. Okay, so basics of therapy, A, B, C, D, E, easiest to remember. Aspirin, blood pressure control, cholesterol, cigarettes, diet, and exercise. A, B, C, D, E. A, B, C, D, E. Next slide. Give it to me straight, Doc. How long do I have to ignore your advice? Well, the key thing is what Morgan said, which is that, diabetes and when someone comes in for their blood pressure, this has been going on for a while. So the issue is you didn't come in here soon enough. Now, we don't tell people that, but the issue is diabetes is the perfect. You've had diabetes for 5 to 10 years before you show up into the doctor's office. And it's usually found incidentally. It's usually found when you're getting your yearly blood, yearly blood tests, when you're getting blood for something else. So that's why it's important. The answer is you can't ignore your advice. So education and follow-up is key. Next slide. This is what we do in our clinic. Okay, so these are all the different things that we do. We do risk assessment. Okay, and I have handouts for you about the different tests and issues we have available. We're going to leave these for you guys to pick up on your way out. Okay, preoperative risk. We mentioned this a little bit. You're going for surgery. You're going for your colonoscopy. You're going to get your gallbladder out. But you've had a previous heart attack, or you're on blood thinners for a heart valve, or you've had a stroke. We get involved in that care because the surgeons want to know how can we help them co-manage the patient through the surgical period. People have chest pain. People have a heart murmur, abnormal blood flow in the heart, irregular heart rhythms, palpitations, heart fluttering, dizziness. That's a very common reason people come in to see us. Passing out without a known reason. You've had a cardiac test, your primary care doctor ordered a heart test for something, and it came back abnormal. They want us to talk to them and talk to the patient as well as to the provider about what does it mean and what else can we do for controlling difficult to control blood pressure. If you're on 3 blood pressure medicines, okay, to control your blood pressure, you should see a cardiologist or the mid-level providers sometime in your care. And people say, oh, they don't want to go to the cardiologist because I don't have a heart problem, it's high blood pressure. Well, it is a heart problem. The other issue is that people say, oh, he's just going to give me more medicine. I will tell you, 50% of the people that come in and see us for high blood pressure leave the office with less prescriptions because they're on conflicting medications. They're on one medicine that affects the other one. Or we can give them a combination of medicine. There's a lot of blood pressure medicines that have 2 medicines in the same pill. Well, if we can combine that, first of all, it works better than taking 2 separate pills, and also it's cheaper because it'll be 1 copay versus 2 copays, and everybody likes that. So you can say, okay, you're leaving with the same number of prescriptions, and that's what makes people happy. So we do that a lot. We didn't talk today about irregular heart rhythms, but that's a very big part of our practice. We also, we could pass this around. I don't know if any of you guys know what a pacemaker is, but this is a pacemaker that we put in if people's pulse is too slow, and we follow that here. And this is something called the link recorder. We put it under your skin. It's like a monitor, but it has a little computer in it, and we can monitor your heart rhythm for a year with this. And this is just a little procedure we put under your skin, and then it sends the information over the telephone. And I don't know if you've probably seen on TV or your friends who have had a defibrillator that shocks you from the inside in case your heart rhythm stops or is really bad. This is what a defibrillator looks like. It basically looks like a big pacemaker. So, we can help you manage that. And these are other diseases that we help co-manage. Morgan is very involved in anticoagulation. She's really getting to be quite an expert on different types of blood thinners, why we use certain blood thinners in certain situations, how we stop blood thinners for surgery. That's a really important thing. And how do you restart it? You know, someone needs their gallbladder out, and they've been on blood thinner for a heart valve for years. Well, how long do you stop it for? When do you restart it? So that's her thing. I've basically shifted that to her clinic, and she's really good at that. And she'll help the surgeon as well as the other medical providers work that out. And she talked a lot about the high blood pressure and cholesterol management. Next slide. All right. Give it to me straight, Doc. I can take it. Is my insurance going to cover it? This is a huge issue, right? People are on a lot of medicines. So the issue is we want to get you on the most cost-effective medication. If a generic is available, we'll definitely prescribe that, and we'll work. Our nurses and medical assistants are great at working with insurance companies to get pre-approval if there's a drug we really think you need, and they've got that figured out. And the last slide is really an important slide for us, is that the inferior doctors treat the full-blown disease. Now, I'm not saying a surgeon is an inferior doctor, but at times somebody needs bypass surgery, you're so far down the line, right? And the mediocre doctor treats the disease before it's evident, and the superior doctors are the preventive doctors. Our goal in our professional life is put the surgeons out of business. It's not like we don't like the surgeons, but we think that with follow-up and aggressive medical care, we can prevent surgeries unless they're absolutely necessary. And then we'll help take care of you after your surgery. So our goal is to do that, and you can see that. You've probably heard about valve replacement, that they don't have to open you up for open heart. They do it through your arteries and veins now. That's a huge improvement in care, and the recovery is incredible compared to someone who needs open heart surgery. So there's all kinds of technology that's changed over the years. And our final slide is the slide I promised you, that this is from the exact same spot after the sun came up. okay? And now you can see the mountains, you can see the ground, and you can see everything else. So here, just before sunrise, you can't see anything. Then hopefully after our talk, it's a little clearer. It gives you a better idea about what we do and how we can help you guys. You know, what is your cardiac risk? How can we help treat you, make you feel better, you and your loved ones, and make you live longer? So we appreciate your time. We're happy to answer any questions. We are going to put some handouts out for you on high blood pressure, cholesterol. We have diabetes. So we have all kinds of handouts for you guys to take, and also the tests that we do here at the hospital. So we'll put them out somewhere. And if it's important to you, just take a handout. And please contact your primary care provider, or you can contact us. We'll be happy to see you guys at all. And again, thank you for coming to the Women's Health Fair. I think this is one of the best community service events that we do in the year. It's really special. And we're honored to be able to be involved in this event and in your care. And it's really an honor for us, for you to trust us. So we appreciate it so much. Thank you very much, and I'll be happy to take your questions, and then we have a little raffle. Yes?
If I'm seeing my primary doctor and I have high blood pressure and a heart condition, should I see a cardiologist to help straighten me out somehow?
I would talk about that to your primary care provider. Primary care providers are very good. They have a lot, they do a lot, and they have a lot of responsibility. So I would say in certain conditions, for example, if you're on more than 3 blood pressure medicines, it would be a good idea just to see a cardiologist, just to see if there's anything else that's requiring you to take 3 medications. If you've had intervention, if you had a stent in your heart or your legs, you've had bypass surgery, you need follow-up care over time. I mean, the surgeon hasn't cured the disease. They've just treated your symptoms, which is your chest pain or shortness of breath. So every 3 to 5 years, you need another stress test or an ultrasound to see how things are going. People that have a heart valve replacement, you need an echo every couple years, an ultrasound to see how things are going. So, you know, it's as much to help follow your care then, I mean, we're not going to take over their management. Trust me, we don't want to be primary care providers. But what we are experts in this world, and we can give advice and what we call co-managing your case with your primary care provider.
And a blood thinner too, you said that?
Yeah, we do that. That's Morgan's area of one of her areas of focus is blood thinner management. And we have protocols for that. You know, how to take it, what dose to take, because some of them do change with age, they change with your kidney function, you know, how often do you need your tests done, and all that. And, you know, she's got all kinds of handouts for you and your provider and special goals that is based on national recommendations for how we treat these situations.
So you can suggest this to your primary doctor?
Yeah, say, look, yeah, exactly. I think, you know, I've had this condition, you know, I think it's time for me, you know, what do you think about me being checked out by a heart doctor? And just work it out with them. Yes?
Okay, if you take blood pressure medicine and it's low, 20 milligram, and it does perfect, it doesn't, I mean, you can keep it low and manage it.
Yeah.
Do you recommend taking a blood thinner like an aspirin, 81?
You still need an 81 milligram aspirin, and the reason is you have a risk factor. Okay, so blood pressure, keeping your blood pressure down to 120, 125 for the top number. Remember, Morgan mentioned the top number is what we focus on in people over the age of 50. It's still important to take an aspirin because these little micro clots, like I showed you on that slide, could still occur, and it prevents those tiny clots. So a baby aspirin, as long as you don't have bleeding or anything like that. But I would discuss that with your provider. Diane?
Oh, are you all concerned, I'm sure you are, with marijuana being legalized now, with the heart rate going up, even if you're not smoking, you know,
right,
taking it in orally or smoking it?
Well, that's okay. You want to take that one?
Oh, that's okay. I was just wondering if that was going to be starting to be on questionnaires and stuff.
It is going to be on. Yeah, go ahead.
Yeah, so it certainly is something that we as your healthcare provider need to know, so we can take that into account as far as your overall management and placing increased stress on your heart and overall system.
Yeah, I mean, I think that one of the biggest challenges with legalizing marijuana is that people are going to assume that it's safe just by the fact that it's legal. You know, what's the big deal? Well, the big difference between smoking marijuana and cigarettes, the cigarettes have been around a long time, and we know what the long-term risk is. We really don't know what the long-term risk of marijuana is, okay? And also, there's no regulation whatsoever. So it's not like alcohol that, you know, if you take a certain amount and we measure your blood test, we know that you've had a drink in the last couple hours, right? We do that when you come in the ER after you've had a car accident or something. Because you metabolize alcohol with one shot of whiskey or one beer or one wine per hour, right? So if you come in and your blood level is high, I don't really believe what you tell me because, oh, I haven't had a drink in two days. That's impossible, right? Because unless your liver's shot, which most of the time is not true, you've had a drink within the last couple hours. We can't do that with marijuana. It becomes a huge issue. Businesses are dealing with this. Trust me, this is a hot topic in all businesses because the question is now, you know, you're allowed as a business to not allow a positive drug screen in your business. I mean, that's still the law, okay, and it's a federal law. Like here at the hospital, we get federal money. I mean, half our money comes from the government. So, you know, we are at risk of losing that because marijuana is still not allowed by federal law. Right? So we have very strict rules, and if people have a drug screen for some reason, and even if they have a card for medical marijuana or they're positive, we do significant counseling about that. And every case is different, but still we're very strict about it. And so we ask that. We put that on your medical list like a medication. Yes, they're using marijuana. They're using CBD oil. And we put that on your medication list. So it's really important for us as providers to ask that question and to make sure it's listed in somebody's medical file. Great question.
Is it, you mentioned baby aspirin to me before. Is a regular aspirin okay?
Yeah, absolutely. It's just GI tolerance. Oh. And the good thing about a regular aspirin, a 325, it's 4 baby aspirins. So aspirin lasts 5 days in your blood. So to get the same level, you could take a regular aspirin 3 times a week, Monday, Wednesday, and Friday. And it has the same effect in your blood as taking an 81 milligram aspirin every day. And sometimes people like that. Other people say, I just want to take it every day because I'll forget. I get it. Okay, whatever works. But a full aspirin 3 times a week or an 81 milligram aspirin every day is equivalent in your body.
Thank you.
Yes?
Okay, back to kind of her
What
question.
hit the lights
The
button?
CBD and the CBG oil, which is not,
Yeah.
no THC, is it
I don't. The answer I'm being, I don't know.
causing any issues with blood pressure or liver or?
Well, blood pressure definitely. Any kind of smoking is going to.
Well, this is not smoke, this is just an oil.
Yeah, I don't know. I don't know the answer. Yeah, I don't know the answer.
I think there's not been enough studies performed yet for us to know for sure the lasting effects.
But you personally would say no?
Right. We generally say
Would
no.
advise against, because we don't have enough data to suggest otherwise.
Okay. All right. Yes.
Okay, one more question.
Yeah.
If your cholesterol's over 200, but you have a very high,
HDL.
yes.
Yeah.
And
Okay.
So your ratio's really high.
Right.
Is that bad?
Okay. So for primary prevention, okay, in other words, if you haven't had a previous event, the best risk factor stratifier is the ratio of total cholesterol to HDL, okay? And if that's under 3, you're good. So if your total is 300 and your HDL is 100, and that's not uncommon, I think we're still good. We'll talk to you about diet, but we wouldn't necessarily start medication. If your total cholesterol is 300, your HDL is 60, it's technically high HDL, but the ratio is still 5 or 6, so that's high. Those patients we would generally do dietary intervention, exercise, and a statin. So, but if you had an event, if you had an event, as Morgan said, statins make you live longer, no matter what your cholesterol level. So, and there are other medications besides statins, because some people might tolerate it. So we have 2 things, right?
You said more info over LDL?
No, it's total over HDL.
Ratio.
So we have, so if, I don't know if any of you guys have irregular heart rhythms. I don't know, palpitations, heart fluttering, or anything like that. Okay, so we have a neat little device. You've probably seen it on TV. It's called a KardioMobile. It's actually really very cool. Basically, it's a telephone-based app you download on your phone, and then you put your fingers on the little jabbo in here, and it tells you your heart rhythm right on your phone. Okay, then you can store it, and you can email it to Morgan or me or your primary care provider, or show it to us when you come in the hospital. It's like an Apple Watch, but it's more sophisticated. And we have a couple of these that we're going to give out. And then I want to remind you about our handouts. We're going to put them somewhere.
I'm just going to turn this around and they can grab them.
There you go. There's our table. So we have 2 KardioMobiles. If you don't think you need it, then we can pick another name. But we have 2 of these available for you guys. And the answer is?
Rosemary Francis.
Oh, Rosie.
There you go. Oh, I'll be darned.
There you go. All right. Have somebody help you download it to your phone because it really works well. Okay. Next. Dun, da, da, da.
And Kathy Flugel.
There you go. Could you use this? You think that'll help you? There you go. Okay. Good deal. Okay. Now we're going to flip this podium around. And like I said, we have handouts for you on cholesterol, on blood pressure, and diabetes, and testing that we have available here. Thank you, guys.
Could you tell me a little bit about this Women's Festival?
Yes, the Women's Health Fest is an annual event that we have to highlight women's health, and then we like to bring in some fun and activities for the women to enjoy. We have speaker presentations. We have our women's wellness services. That is one of our clinics that's here to help women with some of the healthcare questions they may have and things that they'd like to know when it comes to their health. We want women to be healthy. We feature lots of things. We have the vendors that support things. We have other services that we feature. One of them is good nutrition. We want to make sure they eat healthy, and that's why we have our Garden of Health. So there's so much going on, so much to see. We talk about cardiac care. We talk about lots of different things in the healthcare arena, and because we want the women of this community to be healthy, and then we try to offer them some fun things. There'll be some massages going on. We have Prism Hair here, who they are doing hair, and we have flowers. We have so many things for the women to enjoy, and it's all mostly free.